Hello, and thank you for joining us. We're excited to invite you to watch our recorded webinar, Strengthening Health Systems in Fragile Contexts: Insights and Strategies for Post-Conflict Recovery and Resilience in Tigray, Ethiopia. This webinar is part of the HEAL Initiative for Health Public Health Advocacy Program, an initiative dedicated to rebuilding healthcare systems devastated by conflict in Tigray. Through evidence-based research and human-centered advocacy, HEAL Initiative works to bridge healthcare gaps, mobilize resources, and drive policy change to ensure essential healthcare reaches those who need it most. This session brings together distinguished experts. Dr. Azeb Gebreselassie, a lecturer in global health at the University of New South Wales and an award-winning researcher specializing in health systems. Mr. Mengistu Hagatsi, a health systems expert and researcher at Mekelle University, with extensive experience in healthcare quality management. Moderated by Dr. Tsiga Toole, a dedicated medical professional with experience in clinical services, program coordination, and public health advocacy. This webinar is an essential conversation for anyone invested in rebuilding healthcare in fragile settings. Watch now to gain valuable insights and join us in advocating for sustainable health solutions in Tigray and beyond.
Into our today's discussion. Now I will invite Dr. Azeb to take the floor for her presentation. Over to you, Dr. Azeb.
Thank you, Dr. Tsiga. Thank you for the kind introduction. Can you hear me?
Yes,
okay.
We are hearing you. Thank you.
Okay, thank you so much. And I will maybe turn it off the camera so that I will be more, you can hear me well. So yeah, apology for that. And would I share my slide or? Hopefully, you can also see the slides.
Yeah, we are seeing it.
Okay. Okay, thank you so much. Thank you for having me, and it's really, truly, actually, a privilege and honor to be part of this forum. And yeah, as Dr. Tsiga mentioned, my role is to present lesson learned from global evidence synthesis, and basically I will focus on some of the key areas that we need to consider during the rebuilding health system in fragile and conflict affected setting like Tigray. But I didn't know we only have 10 or 15, around 15 minutes, but I will try. So basically, my presentation is I will briefly touch on the background and the challenge of health affected by conflict and fragility. And I will also briefly touch the impact of conflict on population health and health system. And the main part of my presentation will be around the rebuilding process, and this is a global lesson learned, and as you mentioned, Mr. Mengistu will present on the primary data he conducted in Tigray. And finally, I will touch the new framework which focuses on the WHO framework that touches the humanitarian development and peace nexus in Africa. Probably that will enhance our discussion. But before I begin my presentation, I would like to say a few words. And basically, I would like to acknowledge you, all of you. I was looking at the list of participants, and all of you having the first-hand experience in witnessing the impact of conflict and the conflict or the war in Tigray. And you have been involved and extremely involved in working through the operational side or the research side, basically, and navigating the health system resilience in Tigray. So what I would like to say is, like currently, like away from Tigray, although I'm from there and I worked there for some time, absence at this time may enable me to have a full picture. So my role and my presentation will be focusing on the global insight, highlighting a common challenge, and I will probably open up for discussion. And this quote from the new book published by Shea Bumbulla will be one of the positionality for my presentation. And just to start with the background, as we all know, nearly 25% of the global population currently live in conflict, displacement, or related violence-affected settings. And according to the Global Peace Index, 97 countries reported deteriorating in peacefulness recently. Similarly, the conflict index also highlighted 1 in 8 people are estimated to have been exposed to conflict so far. And among these countries, 50 countries ranked as highly or severely affected by the conflict. And as you can see from this, the conflict index ranking, Ethiopia is also part of considered as highly high in the index level. And such armed conflict and violence basically impacts the health system and the broader population health. And I will not go to the detail of this, but particularly I would like to focus on how the conflict and war impacts the health system. And through the recent evidence and through we also witness the impact. The conflict have a massive impact on the destruction on health infrastructure, and it weakened the governance and coordination mechanism. Importantly, there is a massive displacement of health workforce, and it also have other impacts as well. And in Tigray, we all witness, and you all of the coordination, the challenge between the challenge in terms of coordination of resource and the political situation between the local and the central government bodies. So in any situation, generally, these are the key experience or the lessons for rebuilding and health system. One is to coordinate actors and resource to align effort and prevent fragmentation, and strengthening governance capacity by integrating policy, networks, and power structure. As I mentioned, it's really critical. And it also requires balancing the external influence to prevent dependency and power imbalance. And we know that especially the big actors and donors, they have big influence and power, but we have to continue advocating for they have to support local efforts, and they have to strengthen an existing health system rather than overriding or like working in silos. And finally, it also requires transparency and accountability. And in terms of healthcare financing, this may be my personal view, but usually we know that power or money has a power, and this means the resource control or the person or the stakeholder or the actor that have the money affects the national and subnational power relationship, which means it creates dependency between the donor and the recipient, whether it's a nation or region. So when we focus on resilience health system, the development of sustainable and resilient health system, it requires a predictable source of funding and the development of individual and institutional capacities. But however, we know that, especially at this point in time, basically it's like a dramatic change in terms of the global landscape, and that impacts the funding structure, especially with the US election. So whatever the case, we have to design innovative resource mobilization strategy, both locally and externally, to fill these existing and anticipated funding gaps. And through research funding or other funding, we have to secure sustainable and long-term funding from both domestic and international source. And as I mentioned, those external actors and all the stakeholders has to align their aid or their resource with the national health priority so that it will enhance health system ownership and sustainability. But in most of the cases, all our effort has to be focused on designing funding mechanism that will reduce out-of-pocket expenditure, and it also enhance universal health coverage. So I'm not quite sure how many minutes is remaining, but I will be very brief in terms of health service delivery, because we all know we are all part of this process. But generally, for health system rebuilding and health system recovery and rebuilding, which eventually for resilience require reorienting and redesigning model of care, and which this requires alignment and harmonization of service across policymaking, during planning, implementation, and evaluation. And importantly for us, because conflict and war, basically, one of the as we mentioned, there is a surge in disease burden, and there is also acute surge in trauma, which requires redesigning of the essential health services, and which I know there in Tigray we have a different initiative going on to redesign the health extension program, to redesign primary, like strengthen the primary health care. But I would like just to include this because these are other key aspects of the rebuilding and resilience process. So in terms of health workforce, it's by itself, it requires a lot of discussion, because the health workforce is one of the pillar. It requires a lot of innovative strategy to develop health workforce, how to retain and like maintain the well-being of the health workers, and most importantly, especially with incentives and with the coordination, how to coordinate and maintain sustainability is critical. I probably leave it there, but we can also discuss how to retain and like maintain the well-being of the health workforce. But just to highlight, especially with the retention strategy, studies show that incentive is one of the strategy to retain health workforce, especially for staff to work in hard to serve areas. But at the same time, this has its own challenge, particularly when these incentives are not harmonized, and when these incentives are not for all healthcare workers, it will like demotivate the others, and it may probably create a challenge for the health system. So it requires a harmonized effort to prevent disparities and to maintain harmony into the labor market. The same thing with the health information system and the medicine. Probably leave that as it is. And we know, like, finally, I would like to, like, this framework or this document was published last week, and it's interesting, but I will open it for discussion and how do we use it, or probably in the next few years, we probably come across even like studies or country experience that uses this framework. But generally, as we all agree, health system resilience required the integration and coordination of different sectors, not the health sectors only. And as we say, the health system resilience also requires beyond responding to the emergencies. So this is the humanitarian development and peace nexus is one new approach by WHO and other UN organization to tackle the problem around the response in these different pillars. So generally, I will not go to the detail because it's a very comprehensive framework, but the overall aim of this framework is it will enhance, integrate and prioritize health across humanitarian development and peace nexus. And it will also focus on a coordination of effort and contextualization and implement context-specific implementation. And it will also enhance accountability for national and subnational organization. So finally, these are some of the key remarks from the synthesis. Resilient health system require a strong political commitment to good governance, efficient resource mobilization, and ongoing and effective capacity building and coordination. And for us, it must build on our past success, because Tigray has been went through different conflicts, so that we have experience in terms of how to rebuild the health system, how to rebuild the overall system. So it must build on past success while addressing the new challenge and recovery strategies. And the focus has to be on primary health care, which integrate essential service. And finally, as I mentioned, this will be a discussion point, but I really like it to have beyond the health system, how do we integrate different sectors and different components for health system resilience in the future. Thank you.
Thank you, Dr. Azib, for the insightful presentation. You have highlighted the key strategies, the process, and the outcome of the rebuilding of resilient health system, especially after post-conflict. So thank you so much, and I'm sure our audiences will have other insightful questions that will be our focus of discussion. But we will come back to those questions shortly. But first, let's hear from our second speaker. Now I will invite Mr. Mengistu Hagazi to share his expertise on health system resilience in Tigray in post-war recovery. So over to you, Mr. Mengistu. Mr. Mengistu. Over to you, Mr. Mengistu.
Thank you so much, Dr. Tsaga. Can you hear me? I was talking. I thought I was being heard.
Okay.
So
We are with you now. You can continue now.
it's a privilege for me to present my findings in this initiative. Thank you, HEAL Initiative, for inviting me. Our Azib's presentation was amazing. It's very difficult to present after that, but please help me and staying with me. Is it shared, Dr. Tsaga? Can
Yes.
you hear me?
Yes.
Is it audible?
Yes, it is audible. Thank you. You can continue.
So my presentation is on health system resilience. Health system resilience in Ethiopia's Tigray region is a preliminary finding. This project is sponsored by, is funded by the UK government. This preliminary finding, by the way, don't expect the final conclusions. This was I prepared this one in response to the invitation by Hill Initiative to present our finding, my paper published in in East African Journal of Health Sciences, Understanding Health System Resilience to inform recovery planning in Ethiopia's Tigray region. This was published last month. The reason why I'm telling you this one is because I was expected to present about resilience, but I knew that Dr. Azia was presenting, so to avoid duplication, I wanted to present the preliminary findings of my project. So that's why I am telling you that this is not the end of my project, but I am sure it will have some insights on Tigray's condition. Going deep into the broader context of the Tigray region and the fragility condition, Tigray is, as we know, one of the regions in Ethiopia. It's populous, fifth populous actually, fifth in landmass also. Is home of ancient civilization, as where many wonderful remnants of civilization are there. There is a wonderful history of war and bravery, and it's also known for frequent locust infestation. It is stricken by drought every 3 to 5 years. By the way, these are important. We usually miss this one because this is one of the most determinant for health. Tigray, Eritrea, and some part of Ethiopia are being stricken every 3 to 5 years periodically, by the way. This is very important to know and to prepare the health system to respond for this periodic catastrophe. And when we wars, we have seen three consecutive devastating wars in less than 50 years' time. And most recently, we saw the most recent one that began in 2020 was one of the bloodiest in the modern history. Tragically, it was also preceded by COVID-19 pandemic, which shaped our health system before the eruption of the war. When we see the past years before the war, we had improved our life expectancy from roughly 45 years to 65 years. It is a kind of 20 years add into the life expectancy. This shows that we had great achievement in improving health of our society. And we had also remarkable achievements on the health indicators, other health indicators, such as maternal mortality. For example, this one, can this graph be seen fully? Dr. Tsaga, can you see this?
Yes, yes.
Yeah, in 1990, around 1,440 mothers died out of 100,000 live births. Then this was actually improved to the level 186 immediately before the war in 2020. roughly before Monday. This was a study by the Tigray Statistics Agency. And after the eruption of the war, 8 months into the war, we saw a sad increase, which was about 840 mothers died because of avoidable diseases. So that means this amazing achievement was culminated by this war. Therefore, Tigray is uniquely situated in conclusion of our broader context. Tigray is situated in a geography where natural and man-made disasters frequently occur. In addition, we are also home of chronic stressors for health system. Chronic stressors means we have weak health system that is characterized by scarce financing, a critical shortage of human resource, weak leadership, and so on. So having this man-made and natural shocks and chronic stressors is very important to identify and nurture resilience capacities in this region. So it's mandatory. That means it's not a luxury. Therefore, our study aims at exploring resilience capacities in Tigray. We approached it using longitudinal in three times periods to satisfy our objectives. The first objective was to actually let's go to the specific objectives. In 3 time periods, that means before the war, until the Pretoria Agreement, and after that. So we are mapping the key components of the health system across these 3 time periods, and also we are mapping the resilience nodes and pathways in between among the key elements of the health system using the conceptual framework. Actually, I will show you the conceptual framework that we are using. In addition, we are understanding how the system has changed over time in these 3 critical periods, and how legacies and resilience capacities in previous periods have supported or hindered process of absorption, adaptation, and transformation. As you may remember, Dr. Azib was telling us about the responses of a health system in response to shocks such as absorption, adaptation, and transformation. These are responses for, that means resilience responses for any conditions that affects the health system. In addition, we are going to draw lesson of these resilience capacities, and we are going to compile this to inform the Tigray recovery. This methodology, as I have tried to mention it before, is a mixed methods approach. Majorly it's qualitative, but it's going to be supported by some quantitative key performance indicators. It's longitudinal. As I repeatedly told you that it takes the condition of 3 time periods: before the war, during the war, and after Pretoria Agreement. We will analyze our data using thematic analysis for the qualitative one. In addition, we will develop causal loop diagram from the thematic analysis, and also we will employ interrupted time series analysis design for the quantitative ones. That means we will employ segmented regression to analyze the changes over the 3 periods. This is the conceptual framework we have employed. This is being used by Rebuild for Resilience. This is known for studying resilience capacities in different areas, especially in fragile settings. So we began our study by reviewing documents. We reviewed government reports, partners, online resources, and published research findings through snowballing, mainstream media, and newspapers, and published articles. Initially, we reviewed and used about 135 relevant documents, and these were actually published in Gray literature. So we extracted data from this, then we continued our first primary data collection, and now we are analyzing it. Preliminary findings of this is to start on the building blocks. Actually, we used the building blocks framework as a guidance for data collection and analysis. As you know, Tigray had a network of 2 tertiary hospitals, 14 secondary hospitals, 24 primary hospitals, 224 health centers, and 741 health posts. These were connected by a referral system that had around 340 ambulances. 3 months into the war, it was we saw a damage of either completely or partial damage of 80% of these facilities. And this was immediately after the war. That means 3 months into the war. And after Dr. Azeb was telling us about this, 86% of the health facilities were partially or fully damaged even after the Pretoria Agreement. Approximately 11 months after the Pretoria Agreement, this was the data that was done by Hiram's team. So this was due to a deliberate destruction of health facilities, looting, supply chain blockade, electricity cuts, and so it was stark impact on service delivery. The community service still is struggling. So post-conflict, essentially role of when we see the resilience capacities, the humanitarian actors played key role. By the way, their role was amazing, especially during the wartime. The government of Tigray was not as strong as it was before the war. So, especially to hard to reach areas, areas held by different, for example, by Ethiopian forces, by Eritrean forces, they were reached by humanitarian actors. In general, they played key role in sustaining the life of our society, especially the people who were displaced, who were in disease. So, no, in the wartime, they played critical role. We have to recognize that. Currently, they are also active in rehabilitation damaged facilities. When we see to the improvement of the changes in some indicators, when we compare maternal and child health service was better than the maternal one. For example, vaccination coverage here, we went through 20 years time. It was 40, you can see the trend. We had the best in the nation, by the way, full vaccination coverage. It was 67%. And it came into 20%. It was a crucial drop in 2021. And after that, it came back to around 69%. That means this is a good change. It rebounded. This is because child health has people. We were talking about this among ourselves, and they told me we agreed that child health services have more, for example, the UNICEF, Gavi, and other international organizations pushed the Ethiopian government to allow vaccines, for example, during bad times. So the humanitarian one played critical role. It should be recognized. And one of the strategies that we responded, including the humanitarian and the government one, responded using mobile health and nutrition teams. They played critical role in especially hard to reach areas and the underserved areas, IDPs, and so on. Um, the other thing is the private sector. By the way, it has shown an amazing change. After the conflict, we found out that it jumped from 835 to 100, 1,142 facilities, roughly about 37% increment. It ranged from drug vendors to specialized clinics. If you can see my graphs, especially the pharmacy jumped from 75 to 217, medium clinics to from 157 to 213, specialty clinics like that, especially the primary hospitals. Actually this is later data. There is a later data I didn't include here. They become 20, from 4 to 20, especially as primary hospitals, private primary hospitals. They served as an option, a wonderful option actually for the community when the public health system failed. So that is one of the resilience capacities that emerged during the critical time. The challenge for the private health facilities is affordability, and many things are not affordable by the already impoverished society. The war impoverished our society, and uh, and they cannot afford the private payments. So there is an equity issue. There are people who are not treated because they are poor. This brings an immense meaning to the health system in terms of equity in accessing health service. The second challenge is quality and safety in lack of, because there is, we believe there is a weak regulation and low regulatory capacity in the post-conflict phase in general, and in our setting, we believe that there is a weak regulatory, so this may be a challenge. So role of private sector is wonderful, and we take it as a resilience capacity. However, it should be overseen by strong regulatory systems. When it comes to using quantitatively, I took this from Ida Referral Hospital. Outpatient attendances, I took even I considered the time before the COVID-19. The performance in COVID-19, as you see, was increasing. The outpatient attendance, that means before the war, before the COVID-19, the year before the occurrence of COVID-19, Ida Hospital served about 300,000 patients per year. As you can see, it immediately dropped after COVID-19, but it didn't come back after that. The war followed, and sharp reduction, as you can see in November month. In month of November, that means the month when the war occurred, and it slowly increased. Again, it continued like that even now it's similar. That means it didn't back into its original performance before the COVID-19. When it dropped during COVID-19, the war followed. So slight increment, slight improvement, but it didn't back to its the outpatients. That means usually the outpatients come from different the segments of the document. So the delivery service showed resilience. That means, as I justified, surgical volume was affected. That means major surgery done in either, but now it has surpassed the performance before the war, even before Corona. So resilience, it's becoming to its wonderful time. If you can't see, let me keep on presenting. The other mortality, for example, didn't show any significant change. It was 7% before the war, and it's 8% after the war. I don't see any significant change. So that means either is well, either has shown resilience, we can say, in terms of quality. The mortality is the same across this time. There are months that show sharp increment and reduction, but overall, before the war, it was 7% mortality, inpatient mortality. Now it's 8%, 1% only 1% change. So I can say it has shown a positive response. So the leadership and governance, I was in service delivery. When we come to leadership, governance, and decision making, it totally collapsed immediately after the war. That means after some weeks, the hospitals, the health centers, their management, their boards collapsed. Now they are gaining into their original position. They are recovering currently. One of the prominent things that should be seen here is health cluster management. It was activated after 2 or 3 months by WHO, and it worked with interim government, the then interim government. Actually, the government, the regional health bureau changed heads 3 times. First, Dr. Hagos was changed by Dr. Fasika, then Dr. Fasika was changed by Dr. Hagos, then Dr. Hagos changed by Dr. Emanuel. This creates unstable leadership. So this was one of the drawbacks. As a result, this was because of the war, and it affected the system significantly. But health cluster was one of the good coordination mechanisms that brought the weak government plus the different types of humanitarian actors into one. It was collated by Tigray Regional Health Bureau and WHO. One of the best things that appeared was, even though the government was weak, it was leading the cluster members. It should be appreciated in a resilience. It's recognized as resilience. So still it's working, but the government is becoming stronger even in Woredas. So it's being replaced by the government elsewhere. The one thing that should be recognized was the members in Woredas, in districts, are not actively controlled by the Woreda administrators, Woreda Health Bureau heads, as they are being led by Regional Health Bureau. That means the Regional Health Bureau is stronger than the Woredas in affecting the in bringing the humanitarian actors into the government's priorities. Health workforce, as Dr. Azib said, it showed immense, incredible resilience despite the immense suffering. Many died, kidnapped, and significant portion suffer from vicarious trauma, around 82%, burnout, 60 something percent. The most importantly, they 78%, around 78% of health workforce wanted to leave from Tigray. This is devastating, and around 7.7% have left in 2023. This is a devastating one. Before the Pretoria Agreement, it was very slow. That means very low. The attrition was low, but immediately after the Pretoria Agreement, it was a kind of exodus. The coping mechanisms during the war, the health professionals used to receive family support, community support, even in grain, in kind, in different areas. Mental health trainings from the government and partners, and so on. So I think I have taken much time. Going to the finance collapsed immediately, as we know. Still, it's collapsed. We are totally dependent on donors. The CBHI one before the war, I have the data from 2019. It was 58%, while Ethiopia national was 20%. Now it's 0%. They are trying to bring it back. I hope they will bring it back, but I don't think it's easy to bring it into its initial performance. We hope it should come. The donor we are still donor dependency, but it still is inadequate. For example, we have data from December 2021. There was $8 million needed to serve Tigray, but only 1 point something percent was available. Still, the need of Tigray for finance and the support there is wide difference between this. Information system, one of the most affected. Recently, it's being restored. They have distributed computers. They have started the DHIS. They are trying to reinitiate the existing systems. So that's wonderful. But it was one of the most affected. Here we have to appreciate the resilience of universities and research. Tigray Research Institute to replace the gap created because of the collapsed health system in helping the government and the other actors in doing assessments and research. In addition, the partners were collecting information from the areas they wanted to implement their programs before they implement. This was one of the resilience strategies. So research and partners' effort was one of the things that filled the gap between the failure of the information system and the requirement. So in these three processes, I am almost to finish. In the three types of resilience strategies, absorption, in terms of absorption, we saw, and the health workforce, they were supported by government. I mean, the people around, they worked, they were borrowing. This is considered as a resilience strategy. Adaptation, the health workforce, health extension workers were there was a training by health extension workers, the training of other health professionals into health extension program. This is one of the adaptation strategies. The transformation strategy, the private sector is considered as transformation strategy, and the mobile health and the nutrition teams is also one of the transformation strategies. This is my preliminary finding. Next steps, there is a lot to go into the project. So I'm sorry I took a lot of time. Thank you so much for your patience. Over to you, Dr. Saga.
Thank you, Mr. Mengistu, for this great presentation, which shows us on the current health system situation in Tigray and the challenges for resilience and also the history reflections as well. So we are so thankful. And now the time is we will move to the discussion. Since there are no questions, I will make it open discussion. So our audiences, you are welcomed if you have any insightful questions or any insights regarding the topic. It is over to you. I will give chance to audiences. We are hearing you.
Okay. Thanks so much, Dr. Saga. I really appreciate the presenter, Dr. Aziad and Mr. Mengistu. It was really an amazing presentation. I think we get a lot of points regarding how to create the resilient health system in post-conflict, especially in the Tigray context. It is really, really productive. Saying this, I have a question for Dr. Azieb and Mr. Mengistu. Yeah, since we are living in a developing country, how we are going to establish or create a resilient health system? Because we have a repeated cycle of drought, famine, as well as what you call war. The second question is, it is the 6 WHO blocks are important for the health system. But here, without a political commitment, it is difficult to achieve all the WHO blocks. So how we are going to ensure a resilient health system with a limited political support? Third one is, what could be the mechanism to empower for community engagement or participation? So is there any experience of a country which built a resilient health system following an eruption of bloody war or different problems? Thanks so much. Over to you.
Thank you, Dr. Musi. Dr. Azib or Mr. Mengistu, we can discuss on that. You can answer if you have some insights. You can share until other questions come up.
Let me answer first because Dr. Azib may correct me if I make some mistakes. Do you agree, Dr. Azib? Can I go first?
Yeah, sure, Mengi. But I'm not quite sure if I'm able to correct you. Anyway, just go for it and I will continue.
The first one, by the way, they are important questions. The first one is resilience in poor countries. By the way, resilience is for us because we are poor. Being poor means one of the definitions for resilience is this. That means we are in chronic stressors. That means chronic stressors means shortage of resources and poor management. So we have to be resilient means this needs daily resilience. Being poor needs daily resilience, by the way. Shocks come regularly. That means we have rest some period. But this being poor requires daily resilience means we have to be creative to provide services in a limited resource. That means this is resilience. Second one, political support is definitely in health system, in health policy, as we know. politics determines everything. They call it, I don't like it, but they call it omnipotent. I believe God is omnipotent, but they equivalently call it politics is but determines the health system. So I agree with you, Dr. Musi. I don't have any answer, any other different idea. Community engagement, one of the areas that should be encouraged is community engagement in their own health. In different countries, as we reviewed from literature, they sustain the lives of health professionals. They took care of their own health, especially the public health approach, the nutrition, even the wash, and most health promotion and prevention should be done by the community. So they build facilities and so on. So community engagement has no equivalence in terms of strategy in resilience. Thank you. Back to you, Dr. Azib.
Can you hear me?
Yes, we are hearing you. You can continue.
Okay. I completely agree what Mengistu has been saying. It's really important to have like a resilient health system, especially in resource limited setting. And probably there is nothing to add, but just to reflect what are the key approach for us as one of the country with limited resource is our approach or our intervention has to focus on grassroots level movement or grassroots level intervention, for example, strengthening the primary healthcare system. So because we have a limited resource, investing in community-based services and using the limited resource, the limited human resource and financial resource that we have, it's really important. Capacity building as well. It's one of the key area that helps us to strengthen or build a resilient health system, as we mentioned previously. And the same through if we see through the health system building block, we can emphasize again those issues. With the community, the second one, I will probably, the same thing. I don't have anything to add. But we know that I agree with Dr. Musi. Political commitment is the critical aspect for health system strengthening. We saw that we have broadly in Ethiopia or in Tigray, we have great experience with the health extension program. We have experienced the implementation of improving maternal health condition and HIV intervention, HIV/AIDS intervention. So we witness and we have all the evidence how political commitment is crucial when we have a clear policy, when we have when the government at different level have a strong commitment, and when there is alignment or still there should be a decentralization, but alignment of intervention, alignment of strategies and policies are critical for having this strong political commitment. So I don't think I have an answer for this one at this moment. How do we do it? I don't know, because as I said, you are there, and probably we can hear from the audience. We have very experienced participants in this forum. So yeah, we can hear their thoughts. And probably the last one, as Mengi mentioned, it's very important to have community engagement. But usually for community engagement, trust is critical. For me, the one approach or one strategy to build or to strengthen community engagement is a trust building measure. So the community has, or even the civil society and other part of the population has to get the trust, and they have to be willing to work with us, and they have to they have to be willing to work with us, and we have to get the trust of the community so that we can work, and they have to trust the system, they have to trust the intervention. And yeah, I think those are the key parts. Yeah, happy to hear from the other. Thank you.
Okay, thank you, Dr. Azieb, Dr. Afwerki, and Mr. Mengistu. So we also have another additional question. In addition to the poor and complex political commitment, there is also poor commitment of healthcare providers currently. So how can we be able to create a resilient health system?
So there are also two similar questions in the message box
Yeah,
by Dr. Awad, I think. Is that? Yeah.
yeah.
We have addressed them partly. I don't agree with the poor commitment of health workforce because this is the result of the health system. The health system should take care of the health care providers so that they take care of the patients. This is not perfect cause and effect relationship, as health providers act ethically. They should act ethically and professionally, but the literature says if the health system takes care of the health professionals, they should take care of the patients. Otherwise, the health system may be the cause for poor mental health problem of the health professionals, and commitment. So actually, in my findings, the health workforce has shown incredible commitment. That's why I disagree with poor commitment. Thank you.
Okay, thank you, Mr. Mengistu. Dr. Afwerki, Professor Afwerki is also raising.
Maybe before Professor Afwerki take the floor, I probably would like to highlight as well on the workforce, and we actually highlighted this point in our previous paper on the rebuilding paper, and it's really important for the health system to have a strong adequate health workforce. However, we have to know that this health workforce, of course, like most of you here, are a human being. We went through a lot, and we went through a lot of trauma. Most of the health workers, especially the primary health workforce, are displaced, and they are affected by the war in Tigray. So I don't think this demotivation comes out of blue, because there is always reason. So there are studies done in other parts, like carrying the carrier is critical in other setups. So it's important to design strategies to support the healthcare worker. It's good to provide training, but it's equally important to provide psychosocial support and incentive package, not for the doctors only, sorry for that, but for all the primary health workforce, including the health extension workers. So yeah, I think that will be important.
Thank you, Dr. Azib. Dr. Professor Afwerki, you can continue.
Thank you very much, Dr. Tsagga. Good morning or good afternoon, everyone. First and foremost, I actually would like to appreciate the HEAL initiative for organizing this forum or for organizing such a platform. It's my second time to participate in such a platform organized by the HEAL initiative. I would like to appreciate your efforts, the efforts, and even to continue your efforts. I would say, and secondly, I would like to appreciate Dr. Azib and Mengistu for their wonderful insights. Honestly, it was timely and I would say very up to date information vis-a-vis the current health system or the current status of the health system in Tigray. They have tried to explain, I would say, by using the current status of the health system using the six pillars or the six building blocks of the health system, and that was a very good approach, and it actually helps us to see the impact of the war, the impact of the conflict on our health system. So that was a good job and a wonderful insight from both speakers. Dr. Azib, thank you very much for coming virtually and share your experiences. Don't get lost. It's good that you share your knowledge, you share your expertise, and you share your experiences to your colleagues back home. So that was very much appreciated, Dr. Azib. I have seen a new concept, I would say, in your presentation, which is coined by the term reskilling. I would have loved to hear more about what reskilling is. How is it different from the usual capacity building trainings or the skill building trainings that we are used to? Is it different, or is it a different terminology that you use to convey the same meaning that we are used to? So that is one question that I have to Dr. Azib. And another question to both of you, to both of the speakers, is that do you think that the term resilience is actually a word or a concept that can convey the message that has happened, or the situation that has happened with the health system in Tigray? The health system in Tigray is destroyed or distracted, I would say, and it needs rebuilding, it needs re-equipping, it needs restaffing. Honestly, it needs, re and re. So can we speak of a resilience, or can we speak of the concept resilient for a health center or a health post that is totally damaged? What is resilience for such a health facility? I mean, the only thing that we need is to rebuild that health facility in terms of buildings, in terms of equipments, in terms of supplies, in terms of its human power. So what is resilient for health facilities that requires rebuilding, that requires restocking, that requires re-equipping, that requires resupplying, that requires re-equipping. Can the term resilient, the transformation, the adoption or adaptation, whatever, can those concepts actually represent the rebuilding, restaffing, re-equipping, and whatever for a health facility? So how do you explain if I challenge you, for example, this is a very mild word that has the strength and the power to address and explain the situation that has happened to the health system in Tigray. And then Mange, I actually appreciate the way you presented. You have recognized the works done by the staff of the Health Bureau, Mekelle University, Aksum University, Adigrat University, and the THRI or the results of the damage assessment. Actually, I was very happy to hear that data, but because I have seen in the last presentation of health initiative that the focus was given to the results of the damage assessment from the HERAMS. But Mange, you have clearly indicated the differences between these two damage assessment findings. So you need appreciation for actually recognizing the efforts of the health workforce from the Health Bureau, the universities, and the research institute. I think so much so is enough, Dr. Tsagga. Back to you. Thank you very much.
Thank you, Professor Afwerki. Thank you for the commitment. That's fine.
Okay, thank you for the organizers and the presenters. I want to forward one remark for those of you working around resilience. I feel there are some misconceptions, actually not misconceptions, but a problem of how we can address the issue of resilience. Some of the commenters I seen in the chat box are relating with transformation, and others with community engagement, and the other is with political commitment and the like. So I think one point we need to address is the primary pillar or the primary strategy for ensuring health system resilience is ownership, addressing the ownership issue. So who is the owner of the health system should be first address it. So for resilience to happen, so resilience means the health system and the health service delivery should absorb the shocks and man-made or natural shocks, and should be able to recover from any potential shocks. So for this to happen, the first requirement is ownership of the whole system. So to avoid the political influence for the poor or versus the good political commitment on the health system, avoid any issue of crisis, shortage of resource during crisis and after crisis. The key issue is the ownership. So for resilience to happen, we need to ensure the community ownership, not community engagement. So someone write in the chat box as transformation. So the health system in Africa as all, particularly in Tigray, was owned by the government, ultimately by the government. Still now the government is the owner of the social service sectors, all social service sectors, including education and health. So this should be transformed. The primary owner should be the community. Even the administration should be, the administrator should be the community. The government has need only to have a role of governance and the management and the governance system in the health. Otherwise, the ownership should be to the community. So I want to comment for those experts who are trying to work on the health system resilience in Tigray, that there is a need for transforming the health system from government ownership to community ownership. We know that the government says the primary health care is owned by the community. We know that what's in the government side. We know that the lower level of health service delivery point, the health extension programs and the health posts are owned by the community. But by definition, for resilience, the whole system should be owned by the community, and the government should have only governance and management system. For that, if there is any political disappointment, political failure and collapse, war and other hazards, the community will own and the health system will be resilient despite any political crisis and hazards. So how we can ensure community ownership? This is really complex because it has a political interest, it has an economic issue, a lot of issues. So with the consultation of, some of you, Dr. Gabrab, who was really promoting for community ownership, he was just promoting for radical shifts of the health system from the government to the community ownership. So we do that with his reference and with the experience from the Western world. The ownership of the health system should be transferred from the government to the community. That is the first we need to apply for ensuring resilience. Thank you very much.
Thank you, Tesfai. Thank you, Tesfai, for the participation. So if there is no other questions, let me give the chance to our Dr. Azib or Mr. Mangusto.
Thank you. Okay, can I go first, Mangi, or?
Go ahead, Dr. Azib.
Okay, thank you. Thank you, Dr. Tsaga, and it's really nice to hear from Professor Afwerk, and it's really hard to answer his question because it's a new perspective always. For me, it's really hard, honestly, and thank you for the insightful and really new perspective in terms of how are we in the right way, or are we saying resilient? Maybe first, let me answer the first one. What is reskilling means, and please correct me, I'm wrong, but as far as I know, reskilling the health workforce means reskilling just refers to training, but it may include a new competency to meet the new and evolving healthcare need. So, for example, for our context, for Tigray's context, reskilling, probably the health extension worker previously, they may not be, they didn't have the capacity and the competency to provide promotive and preventive service around NCD, for example, or they may not have the capacity to deal with trauma or any new condition. So when we say reskilling, it's a training, but it's also include a new approach, maybe using of technology, equipping the workers with a new mechanism, probably. So for me, as far as I understood the concept, reskilling, it's referred to training with the new competency to meet the evolving needs of the health system. And for the second question, let me see, can the concept of resilience be necessary at this time? Honestly, like if you remember on my slides, I reflected that because when I was invited to present on this, Dr. Musi asked me to present on the paper that we published on reorienting and rebuilding the health system. But that paper was published in 2021 in the middle of the humanitarian crisis in Tigray. And we focused exactly what you referred, Professor Afwerk, with the concept of how do we reorient and how do we provide emergency services through different mechanisms? How do we rebuild the health infrastructure, the data management system? So we highlighted the points that you raised in the paper, but now I cannot say because I'm not in a position to comment the current status in Tigray, but at least we are in a different phase. So when we say rebuilding or resilience, we are not saying there is no humanitarian response. We're not saying there's no rebuilding process, but through all this process, like immediate relief, health system restoration, long-term rebuilding process, we have to have the concept of resilience, which means we have to balance the immediate response and restoration of service while we are planning and engaging in long-term resilience. So when we rebuild the primary health care, when we rebuild the health post, it shouldn't be the same way that we had before. It has to be in a way that it's respond to the new need or the new the evolving needs of the community. So when we rebuild or when we redesign the essential health package, we have to consider what is the critical or what is the highest burden in Tigray. Maybe it's a mental health or post-traumatic disorder, or maybe a different non-communicable disease. So we have to consider this, but it would be great if I hear your reflection on this and if we all learn from you. Thank you so much.
Thank you, Dr. Azi. I didn't know that I was followed by Professor Afwerki. Thank you so much for attending our presentation. It's a privilege for us. So resilience, actually, Dr. Musi raised something. We are in a poor setting how we can talk about resilience. By the way, resilience doesn't mean high quality care or high quality health system. We can raise the issue of COVID-19. Before COVID-19, Italy was Italian health system was one of the best in the world, and it faced a significant collapse. But Africa showed significant resilience to COVID-19. African health system. That means we are far less than our health system is weaker than the Italian, but was resilient. So this is one concept I want to raise. The other thing, resilience means is forecasting. One thing, forecasting means anticipating that something will happen, and when something happens, responding. When it responds, it should keep the essential health services is one. The existing health services should be there. Plus, it should respond the new need that is created because of the shock or the fragility. And the most important one in resilience is learning from the shock and again preparing itself for another resilience. That's very important. One thing Prof raised was if a health system is destroyed and rebuilt, for example, a health post rebuilt, is it a resilience or I don't know? Is that This is one of the resilience things. I don't know if I addressed it. Tesfaye was raising about community ownership. Community engagement has 4 levels. I know you know it, Tasfish. Community engagement has 4 levels. The last level is ownership. Community orientation is the first. Community-based engagement is the second one. Community management, that means it manages the health system, is one. The third one, the last and the robust health system is owned by the community. That is the last level of community engagement. So that means you are right. Thank you so much. Back to you, Dr. Tsaga.
Thank you, Mr. Mengistu. Thank you, Mr. Mengistu. And Dr. Azib for the insightful discussion and talks. And we have also another question in the chat box, which is about what about if we talk about transformation and breakthrough of the entire health system rather than in focusing only in resilience. So it is trapping us in crisis coping mechanism, which is a dilemma. There is another question which says like this. So if you have anything to add regarding this, over to you.
Let me go first.
Okay.
There are 3 strategies for resilience. The first is adoption. Adoption means managing the crisis within the available resources and structures. This is the first one, and it happens in the first times up to 3 months of the crisis. And the second one is adaptation. That means you made additional resources, but the structure is there. There is no change in the system. The third one, and which is required, is creating a new system. That is transformation. Transformation strategy is one of the strategies required. A new level of achievement, a new system that achieves a new strategy. I mean, new achievements. So transformation is the best strategy. Thank you.
Thank you, Mr. Hagazi. Dr. Azib, do you have anything to add on this?
Not really. Thank you so much for the discussion.
Thank you. Thank you. Thank you all. If we have another question, let me give just one chance. So if there is no another question, thank you. We are on the conclusion. So as we conclude, I would like to reflect on the key points we have discussed today. We have discussed a lot about the importance of the resilience and the current situation in Tigray and the coping mechanisms or the key strategies to rebuild our health system, which is significantly devastated through after the conflict. So both Dr. Azib and Mr. Mengistu have provided us with valuable lessons that can inform our collective efforts in strengthening of the health system in our context. So I have a heartfelt thank you to those esteemed panelists, Dr. Azib and Mr. Mengistu. Thank you for sharing your expertise and experiences. And your insights have been valuable, and I will also I have a gratitude for our audiences for your engagement. Thank you for your participation and cautiousness and commitment to improving the health system. As a key initiative, we believe that those discussions like this are only the beginning, and we encourage all of you to stay engaged and to contribute to ongoing efforts, and also to advocate for healthcare solutions in conflict-affected regions, especially in our region. And if you'd like, we would like you to collaborate and support our initiatives, and please visit our website. And we are also this discussion is recorded for those who are unable to attend live today. So we officially conclude this for today. Thank you all, and we hope to see you soon at our future discussions. Stay safe and continue advocating for stronger and resilient health system. Thank you all.
Thank you.
so
Thank you,
much.
Dr.
Thank you for watching. We hope this discussion has provided valuable insights into strengthening health systems in fragile settings. The work of the HEAL Initiative for Health continues, and your engagement is crucial in advocating for sustainable healthcare solutions in Tigray. Stay connected, share this webinar, and join us in shaping a future where essential healthcare is accessible to all. For more updates, follow HEAL Initiative for Health and be part of the movement for lasting change.